And we're going to learn a little bit about him and cardiovascular services that he provides along with his esteemed colleagues, and how they've helped create this state-of-the-art cardiovascular care center for our community. And it makes it absolutely unnecessary to go anywhere for cardiovascular care because of the leadership of he and his team. So tell us a little bit about yourself to get started.
So I'm Sudhir Prasad. I've lived in Rocky Mount for 30 plus years, and this is home. My kids grew up here. They went to local schools, and I trained in New York cardiology, and then I came to Greenville a year before I came to Rocky Mount and did my interventional cardiology training. When I was training, there was no STEMI call, or that concept had not started. So when I came to Rocky Mount, we used to work with Greenville ECU, and later on when Nash decided to partner with UNC, they were able to bring the STEMI program, which is if somebody is having a heart attack, the dangerous kind, then we need to take them to the cath lab and open these blockages and put a stent in. And they've done a fantastic job under the leadership of Dr. Stauffer, who's the chief of cardiology at UNC, and Dr. Mike Young, who's our medical director, and then Sarah Heenan, who's the director of the Heart Center. They've done a wonderful job, and I am glad that we're doing it here because I live in this community, and if I had a heart attack, I would want the best care possible, and that's what we're trying to give to our population, Nash County population.
Well, given that the earliest perfect care is the best care, being transported even by a helicopter parked in your backyard an hour away is not the best care by definition. In fact, we'll talk about this a little bit later in the show, how care really starts at your house if you have a suspected heart attack.
Seconds matter, and I want to say we have saved hundreds and maybe thousands of lives because of it, haven't we?
Right, definitely. And if that care had to be transferred southeast of here or southwest of here, many of those people would have not survived.
Right.
And so truly a concept in medicine called the standard of care, meaning that you can't get better anywhere. The standard of excellent care truly is delivered by the Nash Hospital cardiology department.
Absolutely.
And there's cardiologists, and we'll talk about this again in a little bit, but first I want to show some slides of the cardiovascular center. We are in partnership with teaching hospitals where if there is any component of care that can't be delivered locally, that partnership can be carried to a teaching hospital, often by the very same doctor that will see you in this town will care for you there.
And we are so lucky to have the specialized doctors at UNC that can deliver excellent care to our patients who live in this community.
Right, the continuity of care.
Yes.
And the fact that the actual doctor who you want to save your life will be the one who sees you 2 weeks later or a month later or 3 months later is very important.
And it's manned 24 hours a day, and that was one of the things you went back because you didn't have the advantage of STEMI training, but
yes,
you wanted to be in that rotation. So.
Absolutely, yes. So when UNC started the STEMI program, I trained with the UNC doctors and was on call 24/7 a day. I would come at 2 o'clock at night and do the STEMI calls. And there's certain tricks that you have to learn how to do STEMI. You just can't.
And define again for us what STEMI means.
So when you have a heart attack, the muscle is this thick. If the heart attack is damaging the whole thickness of the muscle, is called a STEMI. We see some changes on the cardiogram. And the most important thing that I would like to tell the Nash residents is if you have chest pain, sweating, not feeling well, shortness of breath came on suddenly, you should get an EKG because that separates the STEMI or the dangerous kind of heart attack from a non-STEMI, which is a regular heart attack.
And an EKG is where they put electrodes on your chest and it creates those little squiggly lines that we interpret, right?
Yes, sir.
And those squiggly lines mean very specific things to us, and they tell us about the status of your heart muscle and whether it's getting appropriate electrical activity or putting out abnormal electrical activity or starving for oxygen.
Yes.
Okay. So,
And I have a picture which shows that if you came early to the hospital, your chance of making it is much better than if you came 12 hours later. So the deal is to come to the hospital or the emergency room early to get these tests done.
so have a low suspicion if you have symptoms, which we'll review a couple times tonight. But why don't we cue up our slides? We have pictures of the inside, and we'll show, and then you can narrate these for us if you don't mind.
Yes, of course, yeah. So this is the heart center that was built at Nash in 1994, is that right? Yeah? I think so.
Well, it said the
And it's-
center, though, was established in 2014.
Yeah.
So it's a beautiful structure, isn't
It's
it?
a beautiful structure,
was the-
state-of-the-art equipment, and
You think about the Hardy's Heart Center was first established, but
That's
then
right, yeah.
this became
That's right.
the Nash UNC.
heart center, that's right.
And I have to tell you, Dr. Posada, when I was talking to one of the physicians who's here from Chapel Hill, he said, our facility is more beautiful even than Chapel Hill, and it's because it's brand new, but you've got every latest everything. I mean, it's one of the absolutely most well-appointed, it says, facility that there could be, isn't it? I mean, you've got every convenience.
And it's very well
Well,
utilized.
And keep in mind, we're not just talking about how beautiful that bed or end table is. We're talking about the stuff that really matters, where the rubber
Equipment.
hits the road. We have state-of-the-art equipment that's going to help diagnose your problem as good as any place in the world. So this is a very highly technologically driven profession that you're in. And so if you have 2008 technology, you're going to be able to deliver, even though you have 2050 intelligence, you're only going to be able to deliver a 2008 result, right? If you have state-of-the-art equipment and you keep it updated and you keep training, then you could always deliver the quality of care that you can deliver every place.
Well, and when the partnership started between UNC and Nash, in 2019, they evolved even more in that Boyce Willis and the hospital joined forces. Tell us about that.
So I was part of Boyce Willis Clinic Cardiology, where we had Dr. Varma and Dr. Thacker. And I think I have to give them a lot of, because they really brought cardiology to town. Dr. Varma did, he started cath lab, stress testing, TE, and a lot of other stuff that was not done here before. And when he came to town, he started doing heart catheterizations, and people obviously said, oh, you shouldn't do them in a small hospital, but he did such a good job that patients started staying, and he worked with the local doctors at WakeMed.
And again, a heart catheterization is where you put something through a small catheter
Yes.
into a vein.
Yes.
And we'll actually show you one after we take a break and
Yeah.
return from a break. It's a small
It's a long
cath-
plastic tube, and it's designed in such a way that we can inject dye and look at the heart arteries.
But you can trail it all the way up into the vessels of the
We
heart.
can go from the hand, or from the legs, or from the ulnar artery, we can go from many different places.
And you can see points of blockage,
Yes.
right? Not only where they are, but how severe they are. And then you can base treatment on that and actually treat through that.
That's how we decide to,
Right.
to treat.
All right.
But then as they left, Dr. Thatcher and Dr. Varma left, now Dr. Martin, Dr. Stephanie Martin, who grew up here,
Yes,
and
yes,
you
yes.
have an office at Boyce Willis, the big tower. And
When they were
60
leaving, I decided that I'm going to stay here. My wife is very involved in the local community with schools and things like that, and it's been a good place for us to live.
And
Really
he's
has
got
been.
two sons who are cardiologists. Isn't that great? And they went through our school system here.
That's
Yes,
perfect.
yes,
And
yes.
he's extremely proud, as he should
One of
be.
them is going to do interventional cardiology at Duke,
Yes.
and the other one is going to start interventional cardiology at UNC in
That's-
a year and a half. Yes, I'm blessed.
Yes, you are. As are they.
And you're smart, too, and they are.
So again, extreme talent, local, elevating the standard of our care, and thank you for that. Tell us about your partners that you work with and what they bring to the table. And I want to use that as a segue, because everybody, you have partners with different levels of skills, because we don't just deal with heart attacks and blocked arteries. So share with us who your partners are, what their skill sets are,
Yeah.
how that completes our team, and then and we'll use that as a segue to the type of things that are being treated.
So we have Dr. Young, who's our medical director. He's in the faculty at UNC, very talented man for coronary angioplasty, stenting. He does lots of other stuff too.
And stenting means
Stenting means we're putting a scaffolding to open up the artery.
So
Most of
if
the
you have a blockage, you can then open up that blockage.
Yes. So
All through the catheter, not
all
with-
through the
you're
catheter
talking about
without
no
cutting.
no incisions,
No
right?
incision. Then we have Dr. Espinoza, who's also an interventional cardiologist, trained at Greenville. And we have Dr. Joe, who trained at UNC Chapel Hill. And
And that's another interventional
intervention cardiologist, yeah. So there are 4 or 5 of us now. There used to be Dr. Hussain, who just left and went to another facility. And she was also from Greenville. And then we have Dr. Jagannathan, who's our congestive heart failure specialist. There's a lot of emphasis by Medicare and other hospitals to improve congestive heart failure care in the community. And most of the times, these patients have repeated admission, and it's mostly because of education and lack of awareness that salt is bad for them. And so I think the hospital has a lot of responsibility to teach the local community how to take good care of themselves. And we have a specialist called Dr. Jagannathan, Sudha Jagannathan, who trained at UNC, and she's doing a fantastic job in treating CHF patients locally and teaching them. And we have a nurse practitioner who does the same, Erica Mountjoy. So they've been great addition to our faculty.
And 2 other ones new nurse practitioners as well. So it's a complete team.
It's a complete team, yeah.
Yeah, and some of them may actually, if depending on your pathology or what's wrong with you, they may actually have to render care down in Chapel Hill, but those same doctors will come back here and see you in town here, correct?
Yes. And then we have a valve clinic. I should really mention that because patients who have aortic stenosis, it has evolved in such a way that now they can get a new valve in without cutting the chest open. They go through the groin and put a new valve in, just like a heart catheterization. It's called TAVR, T-A-V-R. And specialists from UNC Chapel Hill, Dr. Vavale, Dr. Young, and some other people come and they see these patients, then they take them to UNC for some specialized CAT scans, and then they come back and have all their follow-up here. So I don't see any reason why any patient should go anywhere for valve problem or blocked arteries or congestive heart failure or other things.
Good.
Then we have some specialists that come from Rex. These are electrophysiologists. They put in pacemakers, defibrillators, and so we are very fortunate that we have a complete team of doctors working now in Rocky Mount.
Is there anything that could be wrong with a heart that we cannot take care of?
So we don't do open heart surgery, bypass and stuff like that. We don't have that capability. But over the years, as I was talking to Gene, I mean, the patients who need bypass have shrunk quite a bit. So,
Because most people are treated with these other procedures
Stents.
that we're going to talk
Yes,
about, right?
yes.
And so it's actually pretty much reserved for a few eclectic teaching
Yeah.
hospitals. And so if you can deliver 99.5% of your care, that's unsurpassed anywhere in your local hospital. And if you do need to go for some specialty care elsewhere, if that follow-up is local, you really have a wonderful service to the community and a deal for the patient.
yeah.
Right.
Dr. Prasada, because of having the helicopter there, and that's manned, there's a person who lives there and is available 24 hours a day. And when
mean
you...
the pilots are
The
there.
pilots, yeah, who can fly it. And you told me earlier that when you get ready to do a STEMI, you let them know that just in case?
We make a phone call as part of our protocol. We call them and tell them be on standby.
So if there's an emergency during the catheterization.
Yes.
There's a helicopter with its motor warmed up, and
nursing staff,
flight
flight
path
attendants, yes.
already determined, and the nurses and the pilot that will staff that helicopter are on standby, ready to go and pull the trigger if you have a medical problem during your care here. You're just a quick helicopter flight away, and that's outstanding.
For open heart surgery, if it...
For open heart surgery or there was any complication, something, yeah. So we have been very fortunate. We have not used them, but it can happen, just like life.
And so we keep one helicopter, UNC helicopter here at all times, correct?
Yes.
Right.
Either it's here or at Wilson. I don't know exactly where it is located.
I
but
believe
not
it's
too
here.
far.
It's here.
It's here.
It's right near Coastal Plain.
Okay.
Yep,
Okay.
it's here, and we have 2 helipads, but one helicopter always here, UNC.
And how long does it take if they, and I've seen that, I get tears in my eyes when I watch it land, because I know, I just say a quick prayer, God, help, because I know somebody's in trouble. But it lands there's a pad right beside the cardiology unit,
So
right?
we were part of the team that was deciding when this heart center was being envisioned. And so the helipad was near the coastal plain kind of thing. And I remember Dr. Thacker, my partner, he says, no, that's too far because you have to put them in an ambulance, then you take them over there and it takes 10 minutes, 15 minutes, and it's very critical. And so they made the helipad near the emergency room with the thing that if they needed quick in and out, that's the way to go. And really that has been a very nice thing to have.
And cardiology is right above the ED.
Right above the ER, they couldn't have planned it better. If we come with the STEMI, we are there during the daytime, we take the patient straight away. And everything we do in cardiology has quality measurements. How long does it take for the patient to show up in the ER and get an EKG done? If you're outside that quality measurements, you get bad points, so.
Well, in all actuality, the EKG is probably done before they even get to the ER by the emergency transport personnel. And
They do that too, yes.
And with our protocols, medications are started in the ambulance by the emergency transport personnel. And so your care happens potentially starting in your living room. They're carried out in the ambulance and continued all the way until you're seen in the emergency room. Then that protocol, those of you who don't work in the hospital, it's announced on the speaker system in the hospital that somebody's coming in through the bay who's
Exactly.
having...
We get a message saying that the patient is 10 minutes away.
The whole hospital knows about it,
Yes,
and that's
yes.
an amazing thing.
It is amazing.
It's the whole hospital gears up to save your life when you have a problem, and that's an important point before we take our break, in that we both relish in taking care of our community. We both train to teaching hospitals. We both have the option to work at teaching hospitals, and in fact, I came to this community to initially work at one down the road, and chose not to do so because I didn't want to have anybody else do my surgery for me. I want to control my product. I want to hit a home run every single time. And I don't want to be, I benefited from the training program, and that's a good thing. Everybody did. But there's those of us who like touching the patients ourselves and not really letting students do our work for us. And God bless those who can tolerate that and teach that, but there's something to be said for smaller community institutions that strive to deliver a grand slam on every patient, to have your hands on them. And that's why I think
It is so rewarding to hear patients stop you and say how good care you took of
Correct.
them 10 years ago. It's like
Exactly,
amazing.
because they remember you, because you're not only a member of the community, but you're the one who touched them. And likewise, even with some of the people who render care primarily in Chapel Hill, they'll still come here to see you afterwards.
They still come here and see.
So
yes.
that continuity of care by the person who's actually going to deliver your care is so critical to deliver not only the home run, but to let you know that you got that home run. I think that's an important part of the treatment program.
And you talked, just very briefly before the break, this particular hospital has won 5 awards. That
Major
are
awards,
Major awards, that they have to meet specific and rigorous criteria and performance standards that aim to increase the quality and timeliness of care for heart attack and stroke patients. And time again, they have earned the top awards. So, and
this for American Heart, American College of Cardiology.
So by all pertinent judging organizations, nobody does it better.
yeah, gold
Right.
awards, solid gold awards.
Okay, we're going to take a break now. We'll see you on the back side of
Tell
that
them
break.
what we're going to do.
Oh, yeah, well, I was about to do that.
It's fun.
Well, when we return, you will actually see somebody having a heart attack and what we do to make them better.
And I need to mention about Dr. Martin, Stephanie Martin.
What the community paramedic program is a program that sends paramedics out into the community to help patients after discharge.
It connects the dots for them. He provides education and also to proactively take care of our patients. So evidence-based practice says that if the community paramedic sees the patient in the home, they're able to decrease the readmission rate. It just decreases the burden on the healthcare system.
Taking chronic patients, it takes a toll on all the providers, from the ED to med-surg, nursing, to the dispatch call takers. Some of the things that we do when we go out to residents is we will do vital signs, we will do medication reconciliation, where we take and look through all their medications. We answer phone calls. If patients have questions, we can help walk them through their needs. We can communicate with their doctors. Sometimes they'll make medication changes right over the phone, and that'll help keep a patient out of the hospital so they can be, at home and healthy. We do lab draws for patients who can't get in and out of the house. We do coronavirus vaccines. We've seen patients who were our high-risk readmitters who had been in and out of the hospital get their diseases under control. Most of the time they get a better understanding of their disease process, and they're able to live a healthier life, which is what we want ultimately, is for the patient to be healthier.
Well, after he gets to the routine, he answers all my questions. And he takes the time. I mean, those heart doctors, they whiz in. They're so rushed. And you go, and they're gone. But Till takes the time.
I'm so lucky to have Mr. Till in my life, because if it weren't for him, he would come back and check on me and make sure that that I'm stable and able to go to my doctors and see what kind of meds I need. I won't have nothing.
He's a blessing. He really is.
So being able to connect with patients on a personal level and just talk to them and let them know that it's going to be okay, and that you can be healthier, you can resume a good quality of life. I think that helps the community as a whole.
This is where the public would benefit if they had more Tills out there.
Honestly, I would really like to have at least 10 community paramedics to be able to cover our patients.
The more cars you have, the more people you can help, the more lives you'll save.
Welcome back for the second of our 3 segments in today's show on NASH cardiology and the benefits it's providing to our community. First, I would like to remind you, as we did last week, that if you think that you have a COVID problem, if you think that you're infected and you need testing, do not go to the emergency room. You're not going to get any more rapid care there than if you go to an outside testing center. And at the end of the show, we'll put up a telephone number. Maybe we can do it now. We're going to put up a telephone number. We'll read it off to you for now, but then we'll put it up at the end. And we may not have gotten it ready for him. If we can, it's the health department. It is 252-462-2079. I'll repeat that in a little bit. Call them for where to go for your testing.
They're giving tests there and vaccines
And
there.
vaccines. So you can do one-stop shopping there. Try not to congest our busy emergency room with testing and treatment or routine vaccinations that you can really do at a better location. I will do that. The number is 252. This is for COVID testing now. 252, or for vaccinations, 252-462-2079.
And there's a clinic Thursday. They kind of do it on, they know they're going to do it on Thursday, but they're not giving any COVID tests to asymptomatic people in the emergency room anymore.
Right. So you're wasting your time. If you go there and you wait, you're going to be told to go away.
Heart attacks or
Right.
something.
Yep.
I want to mention very quickly before we show the heart attack, by the way, during the break we showed the Nash Foundation video.
Wonderful group.
And Dr. Prasada, they are talking about the paramedics now, and our hospital has 3 community paramedics. Do you see that they're being helpful with your patients?
They're very helpful. I think it helps these paramedics to go home and talk to the patients. Then they give us a call. For CHF, congestive heart failure patients, they're a boon, because they can get their weight early, they can see if there's any swelling, shortness of breath. So for cardiology, it's a great thing to have these paramedics go in. And I think the hospital has done a tremendous job of moving on with these help to the community, really has.
So let's see our person get saved. Can we roll that video?
Yeah, sure.
Great, thanks.
And they did get saved. We don't want
They
people
did
to
get
panic.
saved, they sure did.
When we get in the cath lab, there's going to be a lot of stuff that want to happen. Out, we're going to get you moved over to the cath lab structure. We're going to report to the cath lab team. Dr. Prasada's team is already in there waiting on us, okay? I've got Mr. Griffin for you here, 66-year-old male. This is our cath lab team. He came into us just a few minutes ago downstairs by EMS, had been having chest pain for about 30 minutes before he arrived. Was identified to have a STEMI on EKG by EMS, confirmed by Dr. Prasada. He has had 324 of aspirin and 2.4 milligrams sublingual nitro. He has bilateral 18-gauge IVs, already has pads on for you, ready to go. Chest pain right now is a 9 out of 10.
I'm gonna move your legs over just a little bit, all right?
Okay, sir, we're going to connect with the monitor.
Mr. Griffin, we're planning to go through your wrist, okay? So I'm gonna roll your hand over this way,
On my arm.
and we're gonna get it positioned for for Dr. Prasada, all right?
Okay.
Lift your arm up and put it on my shoulder. Okay, you can put it down. Do you have any allergies, sir?
No allergies.
All right, so I'm gonna put a little blue towel under your wrist here. And you're gonna feel some tape go across your fingers. It's just to help keep your hands still in case you doze off on us.
What are you doing now, sir? Are you doing okay? Still having the pain?
Yes, my chest is just
Okay,
really
we're going to
tight.
get ready and start to take some pictures and see if we can fix the artery, okay? Hang on.
Thank you.
Give me some gloves. Give me some gown first. One more gown so that Kelly can also throw it.
See, will you drop me a gown?
You doing okay?
Thank you. Thank you.
I think we
Yeah.
can go with
I think your family was already notified about this.
Oh, great. Great.
You want to time out Dr. P?
Yes, time out please.
Mr. John Griffin, this is suspended Dr. Prasada. MR number is 00001234567 Known drug allergy. First, you have prior stent. High blood pressure.
Yeah, I think medicine.
Okay, creatinine is 0.8, INR is 1. Blood pressure is 140/80.
Agree. 1 and 50 please. One of our set 50 of fentanyl.
Clean your wrist off here, sir. It's
Ivy.
really cold, all right?
Okay.
Did you get aspirin in the ER?
Aspirin in the ER.
Okay. Any heparin?
No.
Okay.
My back hurts too.
Yes, sir. We'll give you some pain medication. Just a minute here.
Okay.
Lidocaine? All right. Can I have the wire, please, and the needle?
What do you need?
A sheath, please. Sheath.
Okay.
And I want an EBU 3.5.
What wire?
Run through, please. How are you doing now? Are you doing much better?
Fantastic. Fantastic.
Excellent. We were able to put one stent in and it looks wonderful. And I hope that it doesn't happen ever again. And I'll see you again later today.
Okay. Thank
I'll
you.
go and
Thank
talk to
you.
your family and let them know.
Great. Thank you. Thank you so much.
Thank you, Mr. Clerk.
How is your pain scale, Mr. Griffin?
The pain?
did. So he lived. That's nice.
And he said he already felt great. I mean,
Right.
Immediately, as soon as we put the wire down, the blocked artery, and a little bit of blood starts flowing, they feel so much better.
You're off camera now. What I want you to do is walk around to the front, if you can, and then show for us on this model exactly what we were treating. And do we have the ability to zoom in to this model?
that camera. Oh, there you go.
There we go.
Great.
So this is a plastic model that we're going to use to show you exactly what the pathology was.
This yellow thing is the cholesterol plaque.
So that's demonstrating the inside of an artery, correct?
Yes. And this is our wire over here, and there's a stent on top that when we expand, it gets delivered just like this, and it opens up the artery.
Okay, so that the model on the top on the right shows us that it's a clogged artery, correct? There's a clot
Yes.
in the artery.
Yes.
And then and those are blood cells that are falling down in there, right?
Yes.
So go back to the model at the bottom and go through it with us a little bit slower. So I
let
think
me go
one more
back. Let
turn,
me
one more
finish.
turn,
Yeah.
right?
So this is where the cholesterol is.
So inside, you're looking inside a cut open
Inside,
artery.
that's
And the
right.
yellow stuff is a cholesterol plaque that's
Plaque.
blocking the flow of the artery.
Yes.
It's like stepping on a hose in your driveway. The water's not going to flow through,
So
right?
there are two kinds of chest pain. One is called stable angina. When they exert themselves, not enough blood flows, they start getting tightness and heaviness in the chest. And
Let's stay zoomed in on that if we can for a little bit longer. Thanks,
then
man.
we can put a wire through there and then stent it, and boom,
So that's two steps. The first step is to put a wire in there, and you can show us one of these wires in a second. In fact, stay zoomed in, and he's going to show us a real wire that's used.
this is what we call a
Hold
catheter.
it closer to here so it
Yeah.
stays in focus.
It's shaped like this depending on which artery we have to engage.
No, it goes in unbent like that, of course. The bend in is to help us turn corners and everything, correct? And so this will go inside the artery through the wrist or through the groin, right?
wrist
Through
or
the
the
vein.
groin, yes.
And then you track that up into the heart and then into the arteries that supply blood to the heart.
And there's
Right.
a camera on this too, right?
No, there's no camera. All we do
No.
is we inject contrast,
Uh-huh.
and then we have a camera here and here that takes pictures.
Right, and so what contrast is a material that shows up on the X-ray machine.
On the X-ray.
And on that
It's
video
opaque.
that we saw, you saw this machine above and below the person.
Yes.
And that's a fluoroscopy machine.
Exactly.
That will actually show real live moving picture X-rays of the actual catheterization. And so you can see the blockage and you can see dye injecting. So you'll inject the dye won't flow past the plaque, correct?
Exactly, that's exactly right.
And so you identify where the plaque is, and then you talk to us about, you said the word stent. So after you've identified the plaque, define for us what you mean by stent and how you make the plaque go away and the blood flow go through the artery so that the heart gets the oxygen it needs.
So this is a picture of the stent. Is made of a wire, and there's a lot of technology and experience involved in making these stents.
Could you zoom in again, and so can you hold the stent close? Oh, I understand. So can you, why don't you come around and show the stent against the model that you have here? Are you able to zoom in on this plastic model? All right. Okay, Doc. So I'm giving you a little bit of a white background here. Can you show us the size of these stents and wires that you use relative to this?
So this is the stent, and this is the actual dimension of the heart,
So that's a life-size heart.
life-size heart. These are the arteries, the red ones, the blue ones are the veins, and the arteries get clogged up, heart doesn't get blood supply, they either have a STEMI or blocked arteries suddenly, and in this case, the patient would have stable angina. They exert and they get tightness, heaviness, shortness of breath.
Pain with exercise.
Pain with that's called stable angina. And so this is the actual wire that we use. This is a run-through wire.
And
It's
show
very
us in
fine.
front, show us next to the heart because you're off camera right now. Yeah. Okay, so that's an actual wire.
It's an actual wire.
That will be placed into the beginning of the artery as it supplies blood flow to the heart.
That's right.
And you'll be
Okay.
able to follow the whole thing because the dye is in there.
It's going to show us which way to go. Is
And
it
there's
turned? Is it straight? Is it curved? You know.
And so
there's-
inside the catheter that's inside the vein, now, yeah, show us sideways, show us your hand's blocking it.
So essentially, we come from.
You're blocking the camera, doctor.
Oops.
Yeah.
This doctor is no good then, huh?
He's not a good teacher right
You're
now.
good where it
So
matters,
let's
when
turn
it
it-
matters.
You're infinitely better in the operating room than you are in the TV set. So again, let me show. The catheter, and are you ready to thread it through? Don't do it yet. The catheter, so this goes into the vein, and then...
Goes into the artery.
Okay, goes into the artery, I'm sorry. And now show us threading it. So this blue catheter, you can't see it as blue perhaps on the TV, and there's a catheter that actually goes in. Okay, do you see that? And so the first catheter takes you to the artery.
To the artery.
And then what is this flexible wire doing that you just put through the catheter? Explain to us what
These
this
are
is
the
doing.
wires so that I can look at them on the fluoroscopy machine.
Uh-huh. And
then
what does
I
that teach you?
It tells me if I'm going the right way because not all arteries are straight. Some
Gotcha.
go like this, like this, like this.
And so that helps direct you.
So I can, and then we have what we call a torquer here. There's a small device that I can rotate this, and I can rotate the tip, and I can make it go 90 degrees this way, 90 degrees
So you
this
can
way.
really steer this object.
Steer it, yes.
Anywhere you need to go, because the arteries do not follow a predictable pathway, and you can follow them, correct?
Yes,
All right. And then that can take you right up to the blockage.
Right up to the blockage. Some
then-
blockages are easy to cross, like the STEMI blockages are easy to cross because, as I showed you over here, there's cholesterol plaque. These are called the shoulders.
Uh-huh.
The
And so-
plaque ruptures, secretes a chemical, and clots form right there. And that's what happens when you have a heart attack.
Tell us what happens with a stent.
So what the stent does is it's like a scaffolding that keeps the artery open.
So it's a tube.
It's a tube, yeah.
All right. Do you have one of those with you by any chance?
Let me see.
So basically, if the artery is hurt inside the tube, we can put another tube inside of that that's made out of a man-made material, and that holds the artery open so that the patient's blood flow will go through the artery and bypass the plaque or the damaged wall of the artery. Did I get that right?
Yes.
Okay.
So when I trained, we didn't have stents. We had just balloon angioplasty. It goes and just makes some space with the balloon.
Which means that you go into the area that's squeezed, blow up the balloon, and you expand it.
And all it does is squeezes the cholesterol to the side of the wall, but it worked. You know?
But it worked.
But the problem is that it caused damage and it can close again, so we had to take the patients back to the cath lab. It could take
It
up
was
to
a temporary fix.
It could take up to 6 hours to do one case. When I was training at Greenville, I would go every day at 4 o'clock in the afternoon and work till midnight to do 1 or 2 cases.
Right. And so now we don't use the balloon, the
We
process.
just the balloon we don't use. We mostly put in stents because then they don't close up and then we don't have to go
Because
back
it's
in
a
the lab.
rigid walled piece of man-made material that cannot get blocked.
And they've been around a long time, so people can feel pretty comfortable that they really
Oh, the
stood-
stents have been there since 2000. I know for sure because when I came here in '94, there were no stents. So I had to go to Duke to learn how to deploy stents. It's just times have changed so much.
And is it pretty much permanent, or do people have
Once we
to-
put it in, we cannot take them out.
Okay.
Nor do you want them taken out.
No, we
right?
don't want them.
Yeah.
I thought it was really interesting that that patient, though, immediately he was able to tell you that he
Yes,
felt so much
yes,
better.
Yeah.
Okay.
In fact, just before I came here, I had a call from the ER to go and do another STEMI. So
I hope you had somebody covering for you.
everybody was surprised that there's nobody covering me. So oh my God, on an important day like this. So, but I think we were able to manage it with some other stuff going on.
That's good. That's like hand trauma. We're pretty much solo acts, aren't we? Yeah. So, besides clogged arteries, and which develops into heart attacks, what are some of the other conditions that you treat?
I also treat peripheral vascular disease. So if they have blockage in the legs, arteries in the legs, and they can't walk too much, then me, Dr. Joe, and Dr. Espinoza take care of those. It's called PVD. There's a lot
Peripheral
of-
vascular disease.
That's right. There's-
Peripheral means outside of the main body. It's in your arms and legs.
And there's a lot of advertisement on the TV about PVD or PAD, so we get a lot of questions about them.
And how do you take care of it? What do you do for that?
We do exactly the same thing they do for the heart. We put a catheter here, take pictures, and then direct a wire and put balloon and stents and fix them. The process is very similar, yeah.
And that's true for clogged veins or arteries or both?
I don't work on veins. I think the vascular surgeons work with the veins. A lot of cardiologists have gotten into vein because it's very lucrative business, but we don't do anything that is.
There's a...
Come sit down. We hate to have you.
Yeah,
have to
join us
stand
back over here. February is Heart Month in the United States, maybe much of the world, and so...
And that's why Valentine's is in that
Because
month.
of
Oh,
that.
yeah.
That's
of course,
right, yeah.
Or vice versa. I think Valentine's Day
think
might have been there
vice
first,
versa.
right? And so we're getting ready for Heart Month, correct? Tell us a little about heart failure care at Nash.
So, heart failure, the problem with heart failure is that the patients get readmitted over and over again. And it could be that they're not taking their medications or they're not watching their salt restriction.
So we're talking about people with long-standing cardiovascular disease, correct?
So yeah, so let me go back one step. So when people have heart failure, usually it happens because they have very high blood pressure, the heart gets weak, and they're not able to pump as much blood, so it backs up in the lungs and they get short of breath, swelling of the legs. And the way it is related to heart attacks is that when you have a heart attack, the muscle gets permanently damaged. It's not going to squeeze anymore, you know? So if somebody has a heart attack and the rest of it is working fine, but the front will not move. And to prevent function loss, you need to go to the hospital early and get EKG done, so that if you need to go to the lab, we can fix it so there's no permanent damage. And the way the heart works is as soon as you get permanent damage to the front, the rest of the heart muscle can work a little bit for some time, but eventually the whole heart will become weak like a ball, which is not squeezing at all. It's called ventricular remodeling. And we need to prevent that from happening. That's why it's very important to get that artery fixed early in the game. If you do it in less than 2 hours, your chance of having major complications like this is very little. So,
We have a lot of congestive heart failure in this area, don't we? Does it go hand in hand with some of our comorbidities being high with
it does,
diabetes
because
and whatnot?
diabetes, high blood pressure,
Obesity.
blocked artery, obesity, yes.
And y'all
so-
work really hard to try and educate them.
We've been doing it for years, and it's a difficult battle. It's a very difficult
A lot of
battle.
it's changing food habits too, isn't it?
Yeah.
Well, that's an uphill battle that every primary care doctor wrestles with.
Everyone.
Most orthopedic surgeons wrestle with, particularly those of us who, care about weight-bearing joints that are wearing out. Certainly, every cardiologist worries about it. Or we had guests for peripheral vein disease that worry about it. Our public health guest last week worries about it. It's a huge risk factor for COVID. Survivability, not just infection, but your ability to survive it. But you're on the forefront of that battle. You have to discuss these issues with patients constantly about ways of improving their health.
And I think the hospital has a dedicated heart failure clinic.
The
That's
dedicated heart failure clinic, they have a nurse practitioner. We have Dr. Jagannathan, who's experienced in taking care of this and escalating care if that's what needs to be done. So,
What other types of diseases contribute to heart failure? I'm not talking about diabetes or obesity. I'm talking about what are the cardiovascular diseases For example, we talked earlier about valves.
Valve disease can cause congestive heart failure.
Explain to us what a valve does.
So the job of the valve is to make the blood go in one direction. So if it comes to the right side of the heart, gets pumped to the lungs, and then it gets purified, and then comes to the left ventricle, and the left ventricle pumps all over.
And so there's 4 chambers. And
Four chambers, and there are 4 valves.
to stop any backflow into the other chamber.
Exactly. So that the heart doesn't have to do too much work to keep the blood being pumped forward. But
So
if you
they're
have a leaky valve,
one-way doors that stop, that
right.
make the blood flow only
if you
in
have a
one
leaky
direction.
valve here, it's going to damage the left ventricle. It'll become weak over time.
So if you have a weak valve, the work of the muscle itself could be significantly increased. And if that
Yes.
muscle is starving for oxygen, your chances of a heart attack go up significantly. And then fluid can build up in your legs, it can build up in your veins, it can build up in your lungs. And that's really what we call
Congestive heart failure,
Congestive
yes.
heart failure, right? And that's a big problem for
our community.
it's a huge
major.
problem for our
Yeah,
community.
yeah.
So how do we treat congestive heart failure in somebody who's not had a heart attack?
So when somebody comes with congestive heart failure, my job or any cardiologist's job is to find out what is the reason for it. If the blood pressure is very high, we do an echocardiogram to see if the heart muscle is strong or not strong.
And that's an ultrasound type machine
Ultrasound,
test?
echo machine. Ultrasound is very simple. In 15 minutes, we get a lot of answers. We find out if the valve is working well or not.
It's a painless, state-of-the-art test that we do all the
Painless,
time.
yes.
right?
All the time, yes.
And that gives you valuable answers. And so the echocardiogram comes back and it's positive, that they have, the efficiency of the heart is, let's say, 50%. What would you do?
So 50% would qualify to be what we call HFpEF, heart failure with preserved LV function. And treatment for that is, giving some diuretics, medication that takes some fluid out, telling them not to eat too much salt. And
So there's a dietary program,
the dietary program.
an
Then we-
exercise program, I presume.
Then we do an exercise stress test to see if there's any blocked artery causing this problem. If there's a valve problem, then we figure out it needs to be treated now, or can it wait 6 months, or 2 months, or 1 month, or whatever. So, if there's mitral regurgitation, you got to fix it at some time, otherwise it keeps damaging the heart. But if you have aortic stenosis, the aortic valve gets tight. It's just like treating very high blood pressure.
So in essence, we have at your disposal a battery of non-invasive
Yes.
tests, or perhaps through this little catheter, but you have a battery of diagnostic tests that you can very precisely identify the exact nature of what's causing heart disease. And then once the exact location of your heart failure is identified, then you can enroll that patient into a program that, if it doesn't require a procedure, they can be on the road to health. And if it does require a small procedure, that can be done either
that
locally.
can all be done here locally,
Right.
yes.
And if it's a big valve replacement, that has to be done in Chapel Hill, but it will be done by the doctor that you see here, and will follow up with you here, correct?
Yeah. And even the mitral valve, where the only solution was to replace them, nowadays they have what we call mitral valve clip, where they go and put it's like a fish mouth, they put 2 clips and the regurgitation decreases. And UNC Chapel Hill can do all that for us. It's just amazing how much advancement has happened in the last...
And it's all outpatient procedures, right?
It's all
None of it-
outpatient.
None of it is done with an
Surgical.
open surgery like
Yeah.
it used to be done. So,
And the rehab center too is another part of the treatment
We
plan.
have cardiac rehab center where patients after surgery or MI or stents go in there, exercise, they're taught how to eat healthy, and it's a great program for the community.
And it's
It really is.
supervised too. I mean,
Yeah,
you
it's
have-
supervised, everything's
But
supervised.
I had a colleague who went there, and he said it tremendously helped his quality of life.
They feel so confident that it's being watched so carefully, and they're very good staff. I mean, Mike Sohn and their staff, they're excellent.
part of the other things that you do, though, let's say that the heart, which you've talked about, its pumping function, it also is an electrical machine. What if there's parts of the heart that are not functioning well from an electrical point of view.
So we can find that out by doing that EKG, things. And
And that can help you identify specific parts of the heart
That
that
is
may
not
not be following the normal pattern of
if
electrical.
they are in atrial fibrillation or complete heart block, then we can get the electrophysiologist involved to get a pacemaker in. I mean, I can come in the night and put a temporary pacemaker. I don't put in permanent pacemaker, but
But you can save somebody's life in the middle of the
Yes,
night with a
yes,
temporary
yes.
pacemaker. But what a pacemaker is a battery-powered device that gets implanted under the skin, and through electrical wires, it
it
gets,
stimulates the heart, It'll give a beep if there's no heartbeat.
How is that different from a defibrillator?
So the pacemaker is designed so that if the heart is slow, it can give in energy to capture the heart.
so it uses the battery power to keep the heart beating at a regular
Exactly,
rate.
yes.
And a defibrillator, if
A
somebody
defibrillator is-
stops beating,
If defibrillators on the other side, if the heart is beating too fast, like ventricular tachycardia or fibrillation, it has the power to recognize it. That's what kills most of us. When we are in the last 20 seconds of our life, we have VTAC, VFib, we are gone. So it recognizes that, and boom, it just shocks you out of it.
so the computer inside the box that's implanted in you, which is the
It has
small,
the software,
the
yes.
size of a small little Zippo lighter.
Yes.
Those of us who remember those. The computer in it recognizes the abnormal electrical activity and then makes a corrective electrical impulse.
Exactly.
That resets your heart and instantaneously corrects
Fixes
the
the problem,
abnormal
yes.
electrical pattern. So, in other words, there's a lot of things that can happen, and the care that you can get locally truly is available, both emergently and for long-term care. So,
You were mentioning when we went to the video about Dr. Martin, and you two work together at Boyce Willis, or you've got a clinic
Yes.
together, correct?
So Stephanie Martin was born in Rocky Mount, went to school here. A lot of people know her. And then
Her
she
name was
trained
Falk.
Huh?
Stephanie Falk.
Fuck, yeah. And
Great
I think she
reputation.
trained at, went to school at UNC and then trained at Emory, which is a fabulous cardiology training program. And we are fortunate to have her and provide service for our patients in the community. Yeah.
yeah.
I work very closely with her because she comes to my clinic 1 day a week. And
And she's part of Boyce Willis now.
Just part
Yeah, an incredible institution, very valuable to the health of our community.
And that's been, they kind of merged, so that's UNC
so
Cardiology
UNC
at Boyce
Cardiology and Boyce's
Willis.
Clinic is
Yeah.
like one team now.
That's
Yeah.
a
But she
perfect
doesn't do
combination.
surgery, she does the...
She doesn't do catheterizations now, but
Okay.
she used to at some time.
Oh, did
yeah.
she?
Yeah.
Okay.
Yeah.
The reminder for everybody to not go to the emergency room has to be repeated. If we have that telephone number that we read off earlier, if you could put that up. I have two things to say regarding COVID. One is, please call the 252-462-2079, 2079. If you'd like to know where you can get your vaccine, when you can get your vaccine, and where and when you can get testing. That's the Department of Health.
And the hospital is giving test kits to the health department, and people can get the PCR test there, which they can get the results. That's the molecular one, the one that's very accurate. And Bill Hill told me this afternoon on my way here that people can get the results from that the same day, because the hospital is running those for them, which is really wonderful. So be sure and try and get that. And Thursday, he said they're definitely having a clinic, and they are working on maybe partnering with somebody to do a little bit more regular hours all the time, but you can always call that number you gave and find out when you can go and get the test.
That's wonderful. The take-home message from today, because a lot of the technology blows a lot of people away and we respect that, the take-home message today is if you have any of the symptoms that you maybe even remotely think are a heart attack, chest pain, shortness of breath, pain in your left shoulder, pain with exertion, or shortness of breath with exertion that's abnormal, get to the emergency room. Sweating, abnormal sweating. Anything that is perceived to be abnormal could be, and you deserve to be evaluated by our emergency room immediately.
And what about women? Are there different things that happen to women that
I
they should
remember
look
when I was training, if women came with chest pain to the emergency, we say, it's nothing. But over the years, we've learned that no, they have different symptoms. So I think all cardiologists are now aware that we have to look at them very carefully and not just disregard them.
And not just women, but different ethnic groups have
Yes,
different
yes.
reports of pain and issues. So that type of training and sensitivity is
We have
is
become more
really
aware, yes.
much more aware.
Yeah.
Our guest in 2 weeks is going to be one of the gentlemen who's instrumental
No, 1 week.
in 1 week. That's
1
right.
week.
Oh, that's right. It's next week.
And then Home
Right.
Goods week after that.
Right. Next week will be a doctor who is instrumental in advancing the excellence, not only in your department and certainly my department, but every department of the hospital. It's Dr. Lee Isley. He's the CEO of Nash Health Systems, and we are honored to have him teach us how Nash is grabbing a foothold in our community as the pillar of health education and health providing.
And he's going to talk about the partnership, and of course, the Heart Center is one of the fabulous partnerships we have with UNC.
I've been here for 30 years, and I need to give a lot of credit to the hospital administration for increasing health care in our community, standard of care in our
A tremendous
community.
amount of foresight and guidance, and
Yes.
it really has been wonderfully instrumental in saving tons of lives.
Well, and the other
Wonderful
partnerships
planning.
too. I mean, we've got the Lineberger branch, the Danny Talbot
There you go.
branch of
Yeah. Right.
Lineberger, and just many, many others. The Wound Care Center. I mean, it's just gotten better and better.
It has gotten so much better.
Right. So thank you for joining us today. Thank you, Dr. Prasada. Thank you, partner. And we'll see you next week with Dr. Lee Isley. Thank you very much.
Thank you for listening to us, everybody.
Good night.